I was at Nebraska Heart for the past month, and I kind of have a cheer block back there with Nebraska Heart people. So the guy in the scrubs and there was someone else there, but the lady in the black and green. This is another cool picture. I started out with my experiences. My first days I spent in the cath lab, and that was really cool. You got to see echocardiograms, which are basically ultrasounds of the heart, and they would go in and inject a substance called ISOVU 370, and it appears black on x-rays, so they're able to see where any potential problems are in the arteries going into the heart, and that red arrow shows like an obstruction that may have to later be going, they may have to go in and fix that. Then next I went into arrhythmia, and that's Dr. Ackerman up in the left-hand corner performing a PVI, which is a pulmonary vein isolation, which is a procedure done to treat for atrial fibrillation. The right corner shows a picture of a pacemaker, and then the bottom right just shows what it looks like in. I also went into medical imaging, and there they did nuclear treatments, echocardiograms, which are again the ultrasounds of the heart, and then vascular ultrasounds. And then I did more imaging, which was with CT scans and x-rays, and I got to see a couple patients that had that type of imaging done. I was also able to see some surgeries. The red arrow on that picture shows a mitral valve replacement, or where the mitral valve is, and then the yellow one shows the aortic valve, and I was able to see both a mitral valve and an aortic valve replacement. And the bottom right image shows their preparation for a valve replacement surgery. And there's two different types of valve replacements that you have to look at when you're going to do them. There's a tissue valve, which is on the top, and then the mechanical valve, which is on the bottom. And they both kind of have pros and cons. The tissue valve doesn't last as long, so they'll usually do that on older patients. But if you do the mechanical valve, it does last longer, but you'll have the more likely for the body to clot around there, so you have to be on an anticoagulant to make sure that doesn't happen. And that was another cool picture. One of them showed up. And then for my research project, I looked at women with heart disease. And I have a bunch of facts up there, but some of the ones that I found most interesting was that heart disease is the leading cause of death of American women, killing more than 1/3. And that's about 5 times more than breast cancer, which is really surprising when you consider most women are thinking about breast cancer more than anything when they're looking at diseases. Also, 75% of men survive the first heart attack, while only 62% of women do. And I thought this was a really surprising statistic considering, both people have heart attacks, and women also have been seen to have heart attacks more frequently than men. So that's a really shocking percentage. So for my questions, I wanted to see what the most prevalent symptoms and risk factors for women who have suffered myocardial infarctions, which is another way of saying heart attacks. For my process, I used NextGen, which is a patient documentation software. And I randomly selected 50 patient files, and they were all women who have suffered MIs in the past 3 years. And then I reviewed patient medical history, cardiac risk factors, family history, and then social risk factors. And then this graph shows the most common symptoms for patients suffering heart attacks at Nebraska Heart. And we found that those to be chest pain, dyspnea, which is shortness of breath, pain radiation, and nausea and vomiting. And then when we looked at risk factors, we found the most common were hypertension, hyperlipidemia, CAD, which is coronary artery disease, and being obese or overweight. And something kind of interesting about each of those is they have the potential of being prevented or managed at least by different lifestyle choices. So if you choose to exercise more, eat healthier, and quite a few of those risk factors have the same thing. So like looking at smoking or diabetes, those have a potential of being prevented by different lifestyle choices. This graph shows patient age and mortality. So when we look at it, you see that the majority of the patients we see are between the ages of 51 and 60. And as age increases, so does mortality rate. So the red is the mortality rate. And this is kind of to be expected because as you get older, there'll be more contributing factors and more issues that people can potentially have that will cause them to die that may not necessarily be directly related to the heart attack. And with our mortality rates, within the 50 patients of the study that we focused on, there was a 26% within the first 3 years. But then I went back and looked at all the patients that we've seen in the past 3 years, and that was 560 to look at the mortality rate on a wider scale, and that was 18.3%. And I think that shows like how important your study size is, because that was a significant difference between, there was quite a few more patients that I looked at in the other one, but it shows quite a big change. And then also I looked at a study by the National Coalition for Women with Heart Disease, and they had a suggested 22 to 32% mortality rate within 5 years. So we were pretty close to that area. This is a study by the National Institute of Health, and they were looking at symptoms that women had. And they found the most common symptoms were fatigue, and their least common symptoms were chest pressure and chest pain. When we compared that with ours, it was pretty surprising because it was almost the opposite. With us, we found that the chest pressure and pain was most common, and fatigue was one of the least common. This may be because at Nebraska Heart, they don't necessarily think of fatigue or anxiety as their most common symptoms. We focus more on those chest pressure and like the dyspnea and diaphoresis, which is sweating, that you think are more common heart attack symptoms. And also, it could have to do with the small sample size that I had, which was only 50 patients. For my summary, the risk factors, the top 4 factors are modifiable risk factors, and they can be managed or possibly prevented with lifestyle changes, such as exercise or weight loss. Mortality, more younger patients, ages 31 to 60, survive their MI, so too does rate of mortality. And symptoms, the most frequent symptom reported by patients in the NIH study was fatigue, whereas we found that chest pain and pressure were the most common symptoms for Nebraska Heart patients. So what can Nebraska Heart do to kind of make these more closely related? Identify modifiable risk factors early and work with patients to decrease their risk for MIs. So again, the most common modifiable risk factors that we found were hypertension, hyperlipidemia, and being overweight. And recognize the less common symptoms for heart attack in women, such as fatigue and anxiety, because women do have different symptoms for heart attacks than men do. And then who was involved? There were so many people involved, and I'm probably missing a lot. But thank you so much to Nebraska Heart for allowing me to shadow various departments for the past month, and of course all the people at St. Elizabeth who made this shadowing possible. Special thanks to the research department who welcomed me in and made this internship such a wonderful learning opportunity. And final thanks to Jay Hoffman, Randy, and Susan Crank and Corey Godfrey for helping to organize each of my shadows, working with me to develop ideas and complete my project, as well as teaching me so much about medicine along the way. And I also want to say thank you to all the education coordinators who made this all possible, because none of us would be here if it wasn't for you guys. So thank you so much. Oh, am I okay? Or should I stay up here?
Do you want to show where your family is?
Oh, yeah, you can stand up or something. That's them.